for patients with ER-positive, HER2-negative metastatic breast cancer, they do deserve to have improvement in overall survival. And now that we have trials that can demonstrate improvement in overall survival in the ER-positive, HER2-negative metastatic space, it's very important to pay attention to these trials because over time in history, it's been very difficult to achieve this endpoint in this subgroup of population. The nice thing about the MONALEESA-3 study and the population enrolled is it really does give you a diversity of various patient populations. So half the patients were enrolled as their first-line treatment. Either they were de novo or they received adjuvant hormonal therapy, but more than a year since last adjuvant to be enrolled. The other half actually was treated either as what we call the early relapse population, so patients relapsed on within 12 months of adjuvant AI, or they were treated in their second-line population. So when MONALEESA-3 was first presented and subsequently published, I think it's really added to the consistent effects that we're seeing with ribociclib in ER-positive, HER2-negative metastatic breast cancer. So MONALEESA-3 had a median follow-up of 40 months. The combination with ribociclib and fulvestrant, the median overall survival was not yet reached, but in the control arm was 40 months. The hazard ratio 0.72 is very consistent to what we saw with MONALEESA-7, where the hazard ratio was about 0.71. So to see very consistent results, I think was encouraging. I was not disappointed. In fact, I was very encouraged not to see the median overall survival yet reached in the ribociclib arm. I think as both patients and clinicians, we want to see longer follow-up data presented to give confidence that the initial results is maintained and sustained. And in fact, initially, I can speak that some colleagues were discussing, they were concerned that after a CDK4/6, could the biology be different and perhaps worsened where overall survival is either not met or not maintained over time? So at ASCO this year for MONALEESA-3, with 16 months of further follow-up, I think this really gives us further confidence in terms of the strength and the stability of the results. With now further follow-up on the MONALEESA-3, with 56.3 months of follow-up, one thing is that at that time of analysis, 14% of patients were still on combination treatment. So there are going to be some long-term responders or clinical benefits patients, which is encouraging. I think to see a median overall survival of 53.7 months, so roughly approaching 4.5 years, is exceedingly optimistic for our patients. So the overall survival is really important for patients. They want to live longer, but as many of them say, they want to live longer, but they don't want to live longer at an expense of worsening quality of life. Many patients that present with metastatic relapse have been exposed to adjuvant chemotherapy. So a very common question that I see in my clinical practice is, do we need to treat again with chemotherapy? My experience was not favorable, and obviously the results were not optimal. So to be able to counsel patients that we are not starting with chemotherapy and that we can significantly delay chemotherapy, I think, again, provide some hope to them that we can manage their metastatic disease and potentially prolong survival, but not at the cost of quality life. I think patients do really want to maintain their quality of life, delay the time to chemo or avoid it at all costs if possible, and potentially achieve a survival benefit as well. And I think the suite of studies, MONALEESA-3 and 7 of ribociclib of various endocrine partners, gives you confidence that the combination can perform and enhance their survival